the editor of helpwithaging.com, which is a website that deals with the financial issues of aging, many of which are around cancer or mirror the financial issues of cancer. Obviously, a larger percentage of the older cohort has cancer than younger people, and so this is something he's quite an expert at. He is a senior fellow at the National Academy of Social Insurance, and he also was a reporter for many years, almost a quarter century, at the LA Times as a Washington correspondent. And he also wrote, I love this, Benefits Bob column for the Times for a number of years. So he's been deeply enmeshed in these issues for a while. He has a tip sheet for you. Do you want to hold that till the end, or you want me to?
Might as well pass it out. I
Okay.
thought this would save time so we wouldn't have to look on the websites
Great.
online.
All right, I'm just going to ask you to take one and pass it. And Bob, take it away.
Well, thank you very much. It's a pleasure to be here. I guess for 3 days you've been learning all the details, the biology and stuff like that. I'm going to talk about money, which unfortunately gets wrapped up in cancer in a way that is difficult for patients and for doctors and for family members because it's so complicated. So the first question would be, well, is my cancer drug going to be covered by insurance? And the answers are, I don't know, maybe, and good luck. That's sort of the way the system works. So I thought I'd start out with the Affordable Care Act, with otherwise known as Obamacare. The significant things for that in terms of what we're interested in here is that you can't be turned down for a pre-existing condition. If you have cancer and you want to buy insurance, they can't turn you down. And in addition to which, there is no yearly limit on what will be spent to treat you. So we probably won't see what used to be a common thing. There would be fundraising events in schools or at work. People would sell things to try to raise money for someone undergoing cancer treatment. That probably won't happen because they cannot limit how much they spend in a year on you, or there are no more lifetime limits. So if your treatment costs $10 million and you have good insurance, it's going to cover it. As Linda said, it is to a significant degree a disease of older people. There were 1.6 million cases diagnosed in 2012, and 53% of them, 868,000, were people over the age of 65. And 560,000 deaths, and again, 2/3 of those were people over 65. There are about 14 million people who are called survivors, meaning they have cancer and they've been living with it a certain amount of time. Most of those, 8 million, are over the age of 65. So Medicare becomes a very important factor in how this is covered. Since the war on cancer was first declared by President Nixon in 1971, the number of people who live with cancer has increased quite a bit, increased 4 times. Now, as far as the insurance mechanisms are concerned, what happens is that you apply, let's say you go on healthcare.gov and you apply for insurance. With a disease like this, you have to follow your doctors and the treatment centers because a lot of the cancer drugs are used off-label, which means it may not be easily covered. Each insurance company has something called a formulary, which is a list of drugs that they cover. And the formularies have gotten tougher and tougher because everyone wants to save money. So it used to be there will be a tier 1, let's say you pay $30 copay, or a tier 2, $45. And now they've got 3rd, 4th, and 5th tiers, and in those you pay a percentage. So you don't pay a dollar figure, it's a percentage of the cost of the drug, so 20%, 30%. And if the drug you're taking costs $5,000 a month, which easily happens, you're in for a very big bill. The other problem with the off-label use is that a lot of these drugs were approved by the FDA for one sort of treatment, but let's say your oncologist is using it for something else, well then it's not really in the formulary at all. In other words, then you've got to struggle and get your doctor to say to the insurance company, Miss Jones is using this, which was approved for let's say it was approved for colon cancer, but she's using it for breast cancer, the doctor, would like the insurance company to pay for it. Sometimes they will, sometimes they won't. We'll get into more of that later, but it's very, very confusing.
Can I just interject
yeah,
here before
okay.
we lose this point? I think it's really important, given what we heard yesterday at Georgetown, this idea of looking at individual tumors and figuring out which drug is going to work on an individual's tumor. It's quite possible, I think it's going to become more and more common that drugs will be used off-label for different, so this may become a bigger problem, and somebody needs to be writing about it.
Yeah, they call it, I guess, personalized medicine or personalized cancer treatment. In other words, as you said, the particular tumors. So then that adds this great element of uncertainty. Then there's nothing clear about your insurance coverage. For example, a lot of the stories about the Affordable Care Act say your out-of-pocket limit is, I think, I don't know, 12, just 12,000?
That's for family.
All right, for a family.
Individual.
But that only applies to things which are recognized in the system. And my understanding is that an off-label drug is not recognized as being in that system and therefore subject to the limits. So therefore it seems, if I'm correct on this, that your financial exposure is unlimited. I wanted to give an example. This is jumping ahead a little bit, but I think it gets into the politics of this in a very interesting way. The cancer drugs treat it, but there isn't a cancer drug that cures cancer. There is now a drug called Sovaldi, which cures hepatitis. It doesn't just delay the symptoms, it's actually a cure, and there are millions of people who have hepatitis. Sovaldi costs $84,000 for the treatment. And again, is it covered? It depends on your insurance company. This has led to a big confrontation, which is going to play out politically and in business, between big insurance companies and big drug companies. I guess big insure versus big pharma. And essentially what the insurance companies have said is that Sovaldi, although great, is too expensive, that if everybody, I'm trying to remember them, if everybody who has hepatitis got a Sovaldi treatment, it might add $200 or $300 to the cost of a year, to the cost of everybody's insurance in the whole United States. And so the insurance companies say it's not fair, it's unreasonable, and the drug companies say, hey, it's great stuff, it cures it. Now here's where the politics are really interesting, and here's my first story suggestion. If you go to, let me see this. The cost of Sovaldi in India is $900 a patient, and it's also $900 a patient in Egypt. This is from a good story in Forbes. Beyond pricing this drug favorably in India, once the clinical trials are concluded, the company that makes it, Gilead, has also agreed to work with Indian generic manufacturers to produce the drug locally and perhaps drive the cost even lower. To me, the story is, what happens if you're an American with hepatitis? Could you take a flight to India and Egypt and get Sovaldi there? Would Medicare pay for it? Would your American insurance pay for it? Or would you just go to find a doctor in India or Egypt who will do it? The answer is, I don't know, but I think it's a very good story idea. And it might be worthwhile to call some insurance companies in wherever you work and ask them, what would they do? Would they pony up the money? Because there already is medical tourism. I mean, people go for procedures in Thailand and other places, so why not do it for cancer? And then, on the other hand, would the drug company allow India or Egypt to sell that to someone who is not a resident, a native of that country? I think this is going to come up over and over when, especially as cancer drugs get better, and if there is a drug that's a cure, that will be a tremendous development and probably lead to tremendous political controversy. Yes.
Throw out a quick question. This
Yeah.
has come up over and over again with, the American crazy system. But Has anyone written about why it's so much more here than in India or Egypt?
Well, there are a couple of reasons. One, this is the richest country in the world, hence we can afford to pay more than others. And
No good reason.
number two, what the drug companies say it costs a lot. And number three, legally, the how shall I put this nicely? There's a lot of political power involved here. Medicare is the biggest buyer of drugs in the country. Medicare, by law, is not allowed to negotiate the price of drugs. When Part D of Medicare was passed, which covered drugs, one of the provisions that was put in was that you can't negotiate. Medicare cannot negotiate, and the drug companies agreed. The drug companies backed Part D in return for that. So we have the system. The VA, which operates on its own, can negotiate. The VA gets lower prices, the same prices that Medicaid pays. Medicare cannot negotiate. No one, and then when the Affordable Care Act was passed, once again, that was discussed, but it came about that no, they were not going to allow them to do that.
The other reason is probably, too, because that covered this issue, is Gilead bought the company that did most of the development for this drug about 2 years before it was approved for $9 billion.
So they say they have to recoup their costs.
Super costs.
Wow. What was that company?
Gilead.
No, I mean, what did it buy? That
I forget the name of it
Oh.
right now. Something with a P. Narrows it down.
So anyways,
But it was
Yeah.
about 2 years before.
mhm. Any other questions?
Yeah, I mean,
Okay.
isn't part of it the fact that a lot of these other countries just don't have an insured population, so there aren't the insurance companies so they have to charge more reasonable prices.
Mhm.
The cost infrastructure just does not exist in many countries.
Mhm.
I mean, I guess I've read about that. That's part of it.
Well, they also have much more a regulatory apparatus in England. The National Health Service decides that what's covered and what's not covered. And there's a new drug called, I don't know how to pronounce this, KADCYLA, which is used for treating advanced breast cancer. And basically they said it costs too much money, so we're not going to approve it. And there was a charitable fund set up to help pay for the cost for women who have advanced breast cancer. But basically, when the National Health Service says that it's not going to pay for it, then you have to go out on your own and somehow find the money.
Yeah, what I'm saying is
Yeah.
like there's just like
Right.
a lot less individual private insurance
Right.
in a lot of other countries. There's not Blue Cross of India
Mhm.
competing with Kaiser of India like we have here. So
Right? No. Yeah. They don't.
People to bill.
Yeah, they don't have that sort of thing. Also, the way it's set up in this country, when the FDA considers a drug, it is not allowed to consider price. It's against the law to say we're going to approve this because it costs less than something we already have. The FDA can only look at whether it is safe to take. The FDA also does not look at efficacy, say, is this better than something else? Does it make you live longer? The FDA just looks at the trial and says, did people survive? Did they not die? Did they go through the clinical trial? Therefore, it's safe to take. So that sort of limit means that those decisions then are switched to someone else, whether it's the insurance company or the individual, to worry about it. One of the things that's happening now, I mentioned the tiers, and this is only going to increase because under the 2015 versions of the Affordable Care Act, the different levels, the different tiers are increasing, and the amount of drugs, the number of drugs that are going into these tiers, that's also increasing. Let's see. The most common ones, the silver level plans, it says 41% will require payments of 30% or more for specialty drugs. In other words, whether it's cancer or others, all these drugs are going into that category. While there is no standard definition of such drugs outside Medicare, they are often expensive medications used to treat serious chronic illnesses such as cancers, multiple sclerosis, rheumatoid arthritis, hemophilia, and so on. So all of them now are in the category where you'll be exposed to a much greater payment on your own. The way Medicare looks at this is that you have two choices. Either you can be in original Medicare, which means you can see any doctor or hospital, and then you would pay, let's say, about $100 a month for Part B. Then you would need a Medigap policy, which covers the co-payments that Medicare doesn't. That would cost another $200 or $300 a month. And then you would need a separate Part D, D as in dog, for prescription drugs. And that costs anywhere from $50 to $75 a month, depending on where you live. And you have co-payments and deductibles in that. The Part D issue is that what do we do about cancer drugs? If you buy Part D, each of the companies has a formulary. Is your drug going to be in the formulary or not? And then if it isn't, then you have a big problem. There's no relief in Medicare for this sort of problem. And they're struggling with it. The best they came up with, the CMS said, we're going to give guidance starting in, right now there is no real policy, starting in 2017, that if your doctor appeals, and if the appeal seems to be a valid one, criteria undetermined, then we will require the insurer to cover it. So right now it's sort of Wild West. It's purely up to the insurers. In 2017, they say it will be a more even-handed approach. I've been trying to get an explanation from why they're waiting till 2017, but how shall I put it? The press office is not very quick to respond to inquiries, so I hope that you have better luck than I do in dealing with them.
Can I ask a question?
Mm-hmm.
In terms of Part D of coverage under Medicare,
Mm-hmm.
you mentioned if the formulary for the company you're signed up with
Right.
doesn't cover your drug, you're out of luck. Can you, when you re-enroll the following year, just change your plan, look for one? I mean, now you know, okay, I have cancer and I'm going
Right.
to need Gleevec or
Mhm.
Avastin or whatever it is. Can you just change to a company that does
Yes,
cover it?
that's a good point. I should have mentioned this. Open enrollment, which just ended, it runs from about October 15th to December 7th, is the time when you can choose a new Part D plan. If you go on healthcare.gov and you put in your drugs, and you will find out which plans cover them, and you can look at an individual plan and see where is my drug covered, which formulary is it in. So that's very important to do, to check that every year. They also have, and then it will tell you not only is it covered in the formulary, but are there other restrictions. There's something called step therapy, where the plan says that your doctor maybe can use Gleevec or Avastin, but before that, the doctor has to try everything else. In other words, the step therapy, the doctor has to try other drugs. If none of those work, or if they make you sick, then we, the insurance company, will consider approving the other use. So there's step therapy. There's also something called prior authorization, where the insurance company says the doctor has to get permission from us to use this drug. So not only, when you go online, not only is it important to check the formulary, but also to check the other restrictions in it. And I think here a good story would be to go to the American Cancer Society, go to local groups, and see if you can sit down with some individuals and watch what they do when the Medicare year is up. Watch how their treatment affects the plans they take and the ease or the difficulty of getting that medication that they need. Now let me talk about a further complication with this. Traditionally, the way the payment worked is the oncologist would buy the drug and then have a 6% markup. So the oncologist could buy it for $1,000 and charge 6% on top of that, and that's supposed to cover the oncologist's cost of operating the office and doing business. But this was cut back. Now it's only about 4%. So a lot of oncologists are going out of business. They're closing or they're selling their practices to big medical centers and hospitals. And when you do that, and again, it's very hard to understand or explain the peculiarity of the medical system. Something done in a hospital, same thing, can be a lot more expensive than something done in a doctor's office. So Dr. Smith is now affiliated with here in Washington with Fairfax Inova, a giant system. That same treatment in Dr. Smith's office cost X dollars before. Now the doctor is affiliated with the hospital, costs X plus, a lot more. So that's what's going on. That's going to cost patients more money, again, for the same treatment.
And why was it that was from 6% to roughly?
I think it was, I'm not clear if it was part of the Affordable Care Act or whether it was legislation before that, but there's some step that Medicare took which cut the reimbursement. Let's see. When a doctor is affiliated with a hospital, patients end up paying out of pocket an average of $134 more per dose for the most commonly used cancer drugs. It says, according to a report by IMS Health, a healthcare information company. And of course, and many cancer patients receive multiple drugs.
And why is that? When they're associated with a hospital, it costs more.
Because hospitals are allowed to charge more for the same thing. because
they're a
because
hospital.
because it's a hospital and Medicare says you could do that.
Maybe on the theory that the hospital's overhead is
Yeah,
higher.
that they've got more
They're just
expenses.
amortizing a larger amount of debt. They built that hospital, now they gotta pay for it. It's
Mhm.
that simple, really. I mean.
Okay, that makes sense. So we have that, and then let's see. So we have the oncologists under pressure, people getting in the hospital. And then there is another wrinkle to this. If you're getting something infused, if you're getting the cancer drug through an IV in the doctor's office or in the hospital, usually it's covered by Part B of Medicare because it's regular treatment, and then you have Part B, and then you have the Medigap supplemental policy, so that will control your costs. But if you take the same medicine as a pill in oral form, it is not covered by Part B. It's covered by Part D, and there you're exposed to much greater financial pressures because virtually unlimited. A lot of states have passed something called oral parity laws, under which they can't charge you more if you take a pill than if you get the same treatment infused. This does not apply to Medicare. It applies only to the kinds of insurance plans which are regulated by the states. And most of the big corporate plans are regulated by the federal government, so there's only a relatively small number of plans covered by this. But it's an illustration of how people are concerned and grappling with, well, what do we do about this? There was a bill introduced in Congress that would apply this to Medicare, but it hasn't gone anywhere. And the administration, nobody really is backing it. The administration hasn't been pushing for it, nor have anybody but 30 or 40 members of Congress of both parties. It just doesn't seem to be very popular. Again, I think the politics of it would be very difficult to pass. Now, is that clear, the oral parity? In other words, how you take the drug?
Is it generally explained to the patient, the cost differences?
No, it's not unless your doctor is very conscientious.
Mm-hmm.
So if you're worried about costs, again, the patient should say, the doctor says you have to take such and such a drug. And then the patient should say, okay, where am I going to get it? Am I going to get it in your office or in a hospital outpatient office? Or are you going to give me a pill? And the doctor doctor may not know about the cost of this, so it's important that you ask the question, and then if it turns out it's going to cost you thousands of dollars to take the pill, then you want to take it. Yes?
So like,
In the-
in the case of cancer where you're infusing, say, chemo, right?
Right.
I mean, usually, even if that's in a hospital, that's still an outpatient thing, you're not getting admitted. So are you
Right.
saying that if I get a cancer infusion in a hospital as an outpatient, it'll be under Part B?
Yeah, it probably will be.
Wow. I didn't know that.
Yeah, it will be, because the nature of it, it's in effect a procedure. It's something that's being done to you, and that's covered under Part B of Medicare. You know, it's something you don't give yourself an infusion.
Part B is for hospitalization
Yeah,
generally.
Part B for hospitalization, but also treatments in doctors' offices. Part B falls under that. But if you're taking a pill, it falls under Part D, you know, like taking anything. And that's where you have this tremendous potential liability. And this is not well known, and as more and more drugs are given in oral form, in other words, a lot of the new drugs are in pill form, this is the potential exposure. And of course, if you didn't know this, you would say, well, of course I want to just take a pill. I want to be at home with my family. I don't want to sit in the doctor's office hooked up to an IV. But if it's going to cost you $5,000 a month, you should know about it, and you may,
Maybe that infusion.
yeah, you know, you may act accordingly. Let's see, further complications. Okay, people apply for disability under Social Security. If you have a medical condition, physical or mental condition, under which you cannot work for a year, for at least a year, you can qualify for Social Security disability if a administrative law judge approves it and finds that indeed you cannot perform your job. Social Security had a series of hearings in which they looked at a lot of different conditions, many of which are cancer-related. So if it's metastatic, if it spreads, and they decided that people need help sooner. So if you have one of these conditions, you can qualify immediately for Social Security disability, as opposed to being on the backlog list, which means you wait for a couple of years. And I have on my sheet the listing, the link. It's on the Social Security website. It's called Compassionate Allowances. And this is a long list of diseases, many of them cancer-related, under which you can get a speedier Social Security disability. And that's very important, because a lot of people cannot find they cannot work while they have that. There's also, since we're talking about disability, let me go on to another area which is of interest, and again, often complicated and bureaucratic. The Americans with Disabilities Act covers problems for people who cannot work for various conditions, and cancer is one of these. And there's a lot of information and complications. Basically, an employer cannot ask questions about your medical condition. An employer cannot ask you before it makes an employer cannot legally ask an applicant for a job questions such whether she has or ever had cancer, whether she is undergoing chemotherapy or radiation or taking medication, whether she ever has taken leave for surgery or medical treatment, or how much sick leave she has taken in the past year. The ADA does not require you to disclose information like that before you take a job. What the ADA covers companies that have 50 employees. And what happens is that you are allowed to ask for time off to take care of yourself or someone in your family. And this means that it can be time off to take treatment. And what's interesting, again, one of the links on the tip sheet is to the Center for Disability Rights, which is really good. They have all the experts on these things, so if you have any questions about what people can do and cannot do, they're the folks to talk to. What happens is that you can ask for reasonable time off You don't have to have your doctor say, I have cancer. You can have your primary care doctor can write a note, which you take to your boss, say, so-and-so is going to be undergoing therapy or treatment every Friday from 1 to 3 p.m. And we would like you to know this and make an accommodation. Now, you have to give your boss information from a doctor. You can't just say, I need time off. And then it would be reasonable to say, okay, if I can't work from 12 to 2 on Friday or 9 to noon, can I work extra hours the other 4 days of the week to make up my 40 hours? And that's considered a reasonable accommodation, and the employer is supposed to, under the law, the employer is supposed to go along with that. Other things such as if you have a problem lifting things or carrying things, a reasonable accommodation should be made at work so that something you have to carry is closer to your office, or there are other ways in which you can do it.
Is pregnancy a disability?
That's a different sort. No, wait a minute. I don't know the answer to that.
There's a case
Yeah,
before the Supreme Court
yeah,
right now.
Supreme Court case,
Yeah.
yeah.
Yeah, to be determined.
Yeah.
Oh, so so it really is undetermined and like whatever this case decides will.
Yeah, my lady works for UPS.
Yeah. Split things
She was
situation,
pregnant and
actually.
then when they like working, so she's gonna kick her out.
And the court has that now, right?
Yeah.
Oh, okay.
It was a hashtag for this thing.
Can you talk a little bit more about taking time off if you're taking care of someone?
Yes. Also, if you're taking care of a parent, a spouse, a child, and I'm not sure if other family members included that, but you can, and it's up to 12 weeks, it's unpaid. That's unpaid leave. Let's see.
I've done some reporting on this in the past. While the law is the law, it's not always followed, and some managers, some employers have sort of forced the situation, assuming that the employee would not want to file a lawsuit, so on and so forth. It's some really nasty battles.
What usually happens in those? Does the employer prevail or the employee, or it depends?
If it goes all the way through litigation, usually the employee prevails.
Mhm.
That doesn't, in my experience, that doesn't always happen.
There's been a pushback in recent years against the cost of these drugs. Traditionally, the doctors and the hospitals basically said, okay, if the FDA approves it, then we're going to cover it. We're going to use it, and we're not going to worry about the costs. And that had prevailed for a very long time. And then there was, starting, I guess it was about 2012 or 2013, something significant happened. The FDA approved something called Zaltrap, Z-A-L-T-R-A-P, which in combination with other drugs increased median survival, not by that much, by about 45 days. And then the question became at Sloan Kettering, which is one of the prestigious cancer centers, should we use it? And previous to this, it would be routine. They wouldn't worry about the price, say, well, if it helps people live longer, we'll use it. The cost was about Avastin already was being used, which was costing about $5,000 a month, and Zaltrap was a lot more. And something very unusual happened. A guy named Leonard Saltz, who's head of the gastrointestinal oncology group at Sloan Kettering, decided this was just too much. So he went to the other doctors in the center, and they decided for the very first time, we're not going to cover this drug because of its cost, not its efficacy or its side effects. And that created a big stir and led to not uprising, concern, revolt, I guess you might say, among oncology doctors in a lot of prestigious centers around the country. They said, okay, we now have to take into account what this is going to cost our patients. And somebody came up with the phrase financial toxicity compared to other things like that. In other words, is this going to hurt the person so much financially that they won't be able to afford the treatment, or will be or raising the money will be such a distraction to them that it's not worth it. So there's now a big discussion going on as to how much cost should be a factor, and what we should do about it. What they had determined at Sloan Kettering was the cost for 42 days of Extra Life would be about $60,000, and patients on Medicare, one of the doctors said, would pay more than $2,000 a month out of pocket for Zaltrap. And $2,000 a month is about what the average person on Medicare has as annual income. It's about $25,000 a year. So now the drug companies, basically what the drug companies are saying is that, this is very good. These products help people live longer, and then the doctors are saying, well, we're not sure if people can afford that. So right now the American Society of Clinical Oncology is working up a new program in which they're trying to figure out how do we talk about treatments and how do we advise people on both the medical cost and the financial cost. And they said they will have something coming out in 2015, sort of a new paradigm for treatment. So you should definitely want to keep an eye on that, and keep an eye on what happens with local centers and local doctors who handle this.
What was that figure again for 42 days of Extra Life?
They said it was $60,000 for Zaltrap.
What's the name of that ASCO program?
I'm not sure what they called it specifically, but it's the American Society of Clinical Oncology. I don't know what they're calling that plan. Let's see. Here was something from WellPoint, which covers a lot of people. They have started what they call a treatment plan coordination program. They're giving the doctors $350 per patient per month, the doctors who are treating cancer patients, with the hope that this will enable the doctors to have better coordination with the patients to help save money. The practice bills for that as an additional fee. This is from Jennifer Malin of WellPoint. We selected that amount because we looked at what the revenue was to the practice for using higher cost regimens. And according to our actuarial models, this would keep the practices whole, potentially have them come out a little bit better. The idea is that the doctors won't be worrying so much about that 6%, now 4% markup for oncology drugs, that they now have a little more leeway to take care of their patients and can presumably do a better job. And this is from a doctor who is treating cancer patients, saying, sometimes Saturday night I'm on the phone with a patient and trying to prevent somebody from needing to go to the emergency room and counseling them about how to manage a bad bout of nausea. And my family members, which includes some very aggressive lawyers, are astonished as I get up from the dinner table and they all look at me and say, are you billing for that time? Because they all bill in half-hour increments. And I say, no, I'm just trying to keep Mr. Jones out of the ER Saturday night. And then my lawyer relatives say, you guys don't bill for that? And I say, no, that's not how our system works. So it sometimes strikes the lawyers as kind of funny. So this $350 that WellPoint is going to give the doctors may cover some of the costs of making that phone call on a Saturday night.
Well, but Medicare pays for episode of care, and I think Medicare would consider that phone call part of that episode of care. I don't know where to buy that, you know what I mean? Like, they roll it all into one big payment. So, I mean, you could look at that several different ways, couldn't you? I mean,
Well, Medicare is still basically paying for a particular kind of treatment. Only under some of the plans do they pay for what they call episodes of care. Mostly it's still for a particular, when they do a particular thing to you in the office or in the hospital.
I guess fee for service is different than advantage.
Right.
Or,
Oh, okay. Should I go into that? Okay. Back to what I said, Medicare fee for service, there are 10 or 20 or 30,000 different things a doctor can do, and everything is coded by Medicare. So if you get a knee treatment, it's one thing, you know. If you twist your ankle, it's another. And these are individualized treatments. So you're under original Medicare, you go to any doctor and they add up all of these. And then you have the copayment, and then the copayment presumably is covered if you have Medigap coverage. So that takes care of that. Medicare Advantage, about 25% of the people on Medicare Advantage, which you buy from, let's say, Kaiser or WellPoint, there you have to go within their network of doctors and hospitals to get the treatment. If you go out of network, you're going to be charged a lot more. When you're in network, the advantages are they might cover drugs, they might cover other things that regular Medicare wouldn't. So it all depends on where you're getting your care. I think the advice for cancer patients is probably to stick to original Medicare, because what if the plan you're in does not have the MD Anderson or Sloan Kettering as one of its hospitals? Then you've got to go out of network and pay tremendous fees for that. So probably people with cancer should stay with original Medicare. Does that clarify that?
Well, can I ask a question?
Okay.
Because I'm a little confused.
Okay.
I know that under the Affordable Care Act,
Right.
there are a lot of sort of pilot programs testing the idea of eliminating fee-for-service and moving toward this.
yeah, there's a big movement toward managed care.
Right.
Where you save money now.
Right. So, so overall, Medicare is still basically fee-for-service, but there are these pilots out there, or is that not how it's structured right now? I don't know the answer to this.
Well, the vast majority of people are in original Medicare, which means they go to any doctor or hospital. But if they do that, they should always buy Medigap, which is the supplemental policies to pay your copays.
Right, so they're
That's
under original Medicare.
original Medicare.
The question is, as you were saying,
Right.
there are 30,000 things a doctor can do, and he's
Right.
going to charge for each one, and
Right.
obviously the incentive, the
Right.
financial incentive is to do as many things as
Right.
possible. But now, under the Affordable Care Act, we're trying to move to a different model, where instead of charging for every little thing, physicians are paid for keeping you healthy,
Right.
or for doing things that are
Right.
preventive, and there's capitation. And
Well, also, there's this kind of, like you say, this incentive when you're on a fee-for-service schedule to do as much as you can. That's how you pay for your building and your staff.
Right.
Right.
By billing somebody. So a lot of the managed care contracts, even in the private sector, are rewarding doctors for being efficient and not overprescribing
Right,
treatment.
not doing as
They-
much.
You know, and then there's the ACO model now, where they're actually letting the doctors have a percentage of whatever the spending is below what they
Whatever they say.
projected it should be, so you can actually keep some of the money that you didn't spend.
Right, so I don't know if I'm confounding things here, I'm
Right.
not sure if your question was related to that, or if you were actually,
Well, I just felt like even in fee-for-service, like they have these DRGs, so if you get, I'm not exactly sure how it works for cancer, but I think even in fee-for-service, Medicare will pay a blanket amount for an episode of treatment.
Right.
And I think they expect all the services to be included in that DRG, even on the fee-for-service side.
Well, it depends on the particular doctor and sometimes on the particular hospital as to whether they're carrying it out that way. The Affordable Care Act said we're going to try some experiments and put in some money that we will get, hopefully, the doctor, nurses, social workers, and other people will get money for taking care of you. And because a bunch of these interested parties taking care of you will cost less. And they're just starting to do that. The problem with it is sort of voluntary. In other words, they say they give the money, let's say, to institutions, and institutions will recruit people, but it's always voluntary for the patient. If you don't like, under original Medicare, if you don't like what they're doing, you can still on your own go to a doctor, another doctor, and that will run up the bill. So their ability to do it depends on the cooperation of the patient, and it's not at all clear whether that's going to happen.
I wonder, have you figured out at all whether some of the Medicare managed care products tend to cover the better cancer services in a given place, like MD Anderson or what have you? Or is it generally the case that if you buy a Medicare Advantage plan, you're pretty much making a deal that you're buying something that doesn't have the best cancer treatment in town?
Well, it all depends. That's why, as I said, it's necessary to go online and look at the network and see what's in it.
I understand. I just wondered if you knew what the kind of spread was in terms of
Well,
how common it is that an advantage plan covers a good sum.
Well, I can tell you AP did a really good story earlier this year, and they looked at, I'm trying to find it, they looked at a lot of the Affordable Care Act plans and what was covered in them, and they found a lot of the good centers were not participating, that they had been excluded. Let me see if I can find that. And
That's the ACA, but I was wondering about the Medicare Advantage.
It varies. It varies from one network to another. Kaiser has a pretty good reputation because even if Kaiser doesn't have the particular doctor, they have arrangements with outside ones. So Kaiser has a good reputation. The others I don't know about. The others I wouldn't vouch for as to whether they do it or not. But this becomes a very pressing question.
I mean, as we learned this week, whether or not your doctor knows about the latest techniques could mean your life. Right now, things are really moving fast.
How many of you have written stories addressing in some way the cost of cancer? And how many expect to write more? Yes, it's really a key issue.
There have been people tell me that sometimes they don't feel like a cancer survivor, they feel like an insurance survivor or a financial survivor, which is awful. But that's what it comes down to, is that the stress of the finances is almost worse than the stress of the disease.
Yeah, there was a good piece the other day, and I can't remember where I read it, about a guy who talks about exactly that, how his insurance company, in fact, it was published posthumously, and the headline was something like, "My insurance company killed me," and it was essentially the story of how his doctor recommended a particular treatment. The insurance company fought him for so long that it became too late, and he died. Horrible. But then you have, Karen Sultan yesterday who said, "I have great insurance, and they work with me, and that is not a problem."
And you kind of wonder how many average people become great insurance.
Right, it's a big question.
So that's their employer, wasn't it? That's their employer.
Yes, exactly.
Okay.
Okay, Montgomery
Okay.
County Schools, so, yeah.
One of the important things to note is that, and this may have been discussed in previous days, is that the extension of increase in life expectancy because of these drugs may not be that much more than if you didn't get it at all. Was that mentioned by any of the doctors?
No, not really.
It says the median life expectancy for Provenge, which is used for aggressive prostate cancer, is 25.8 months compared with 21 months for a placebo. So that suggests that maybe the drug works, maybe the person would live a little bit longer without the drug. Then it becomes very much a decision about, okay, what's the quality of life in these additional months, and is it worthwhile? And those are very, very, very difficult questions, obviously personal as well as financial.
And I think the other question about that, given the discussion that we heard about statistics, is that when it says average increased life expectancy about 4 months, does that mean that one person lived an extra year and one person didn't live any extra time. You know, it might be a very individual response to a particular drug. So when you average this whole thing together, you get about 4. But maybe it's just figuring out, which research is still trying to do, which patients are gonna respond best to which drugs, and use the expensive drugs on those people, but not on the people for whom it's not gonna work.
The other problem is these time, average addition to life are based on really, really, really sick people in clinical trials. So that also has to be factored in, and the problem is that, if a drug is available and someone is terminally ill, it's very hard in most cases for the patient, the family, the doctor to say, well, you're only gonna be adding 2 months on average. So it's so complicated.
Quality of life issue is really important too, because these drugs are not just drugs you take. I mean, patients can be very, very sick taking them to the last 2 months of their lives, or it might have been better for them to live 1 month where they would have had good quality of life. And then the overall survival is something that a lot of the doctors have been talking about, measuring drugs based on overall survival, which actually shows that patients actually survive as opposed to the median, which is kind of more subjective.
Right, excellent.
And on ProVeg, the market's kind of spoken on that too, because its maker Dendreon just filed for bankruptcy. So it's part of cost. They were charging an incredible amount. The technology was pretty clunky. They got a lot of hits for their business model, but that was certainly one of the factors. Is like, what does this do for me as far as extending, the statistical basis of extending my life?
So they went broke because people were just not using it.
Yeah, and they just, it was ham-handed marketing as well.
It also was a really iffy drug from the beginning in terms of how effective it was, but, well, one, there was the prostate cancer, advocacy organizations who were very, very eager to have it approved, but the other thing is it was the first immune therapy, and it wasn't very good, but it was the first sort of, this cancer vaccine approach, so, but I'm not surprised that it didn't get much
That's very
uptake.
costly to develop.
Yeah.
Was there any discussion about guidelines in this country versus other countries about cancer in the last couple of days? One of the things that always interests me is that I guess it's because our culture, pioneers in the West, we're much more aggressive in the way things are treated. In Europe, it is not recommended that women get routine mammograms until the age of 50, because the belief is that when you're in your 40s, the breast tissue is more dense and you'll get a lot of false positives. So in Europe, it's a routine thing. It's only when you're over 50. And in this country, it's always been in the 40s. And a few years ago, a task force, and these supposedly the experts, said we should follow the European model and we should change it. But there was such an outcry in Congress and from the public that Congress immediately jumped on and said, no, insurance company must continue to cover it, to cover it when you're 40. So that sort of is a political view of things, which is different from the way it is in Europe. And then the same thing is here. Men routinely get prostate cancer PSA reviews in their 50s, and in Europe they don't think that that's a good idea at all. They say, just check any time if you have a prostate cancer history in your family, come in and check for it. Otherwise, you don't need a routine exam. And now these policies always change. So now it's sort of changing in this country. They're no longer saying get a routine exam depending upon your age, except, however, if you're African American, because the rate of prostate cancer is much higher, so there should be routine testing, let's say when people are 45 or 50. But what's happened is the verbiage changed. They used to say if you weren't going to get an exam, a PSA test, but you did have in your family, we'll do something called watchful waiting. Just go every few years. But someone said, well, that's really not the way Americans think. We need something better, so they came up with a new phrase called active surveillance. So active surveillance is what we now believe in. So that sounds like we're doing something because we're Americans and we like to do stuff. So anyway, so now the standard for prostate cancer is active surveillance.
I think they use it for breast cancer as well.
They're using the same phrase?
Yeah. I've heard that.
So
For
what?
women who have a history.
Uh-huh.
Yeah.
As opposed to getting it routinely, or you mean starting a little younger, right?
Yeah, starting really young.
One of the things I have on there, contacts with the American Cancer Society, has very good website, and they have resources where you can look up local groups. And I think this, again, is very important for, writing local-based stories. I think all of these lend themselves to very good individual pieces in terms of following, A, how people are paying for it, and B, what the local doctors are doing, whether they're changing their habits of practice in response to the increasing cost of everything. So that, I guess in summary, the drugs are getting better. There are going to be more of them, but more and more of the new cancer drugs are oral, or pills that you take, which leads to the complication of how much more you're going to pay for it if you take a pill versus getting into the doctor's office. So that debate is going to go on, and I think it's going to intensify. And then as the Affordable Care Act continues, I think there's going to be a lot of pushback in the next couple of years because of the limited networks, because a lot of the leading cancer centers like MD Anderson and the one in Seattle are not in the networks in a lot of these plans, and a lot of the silver plans. And I think as consumers discover that, there's going to be a lot of concern about it, and I suggest that those would be really good stories to do.
That'd be a great local story, just to look at all the plans in your exchange.
Yeah.
And see which ones have the good local cancer center in them, and run a story about it.
Yeah, in fact, I think the Arizona Republic did a piece about a big center there and how it was only in 4 or 5 of the 20 plans that were being sold in that area. Any other questions?
I have a question.
Yes.
On clinical trials, according to the Affordable Care Act, they need to be covered.
Right.
But if it's at Memorial Sloan Kettering and they're not in your network, is it still covered, or how does that? Like if the clinical trials are usually only done at certain
Right.
facilities that may not.
That's a good question. I don't know the answer to that. That seems, it has 2 contradictory elements. I don't know. That's a good point. Well, thank you very much, and I would invite all of you to check out my website, and also send me an email as you write stories about this, because I'm always collecting stories and would like to use them and link to them.
Great.
So one question
Yes.
about help with aging.
Yeah.
What do you define as aging? Medicare age?
When you start to worry about things, let me put it this way: you're on Medicare, or you're the adult child of someone on Medicare. So I would define it very broadly that way. If you're 45 and your parents are 75 and you're worried about their health and maybe they need help filling things, so I'd say, yeah, anyone on Medicare or an adult child of. So that gives it a pretty broad range of population.
So you're ready for 45
All right, anybody else have questions?
I
Yes.
just have a request.
Yeah.
Could we get the tip sheet in an email?
Sure,
'Cause
yeah.
I'd love to share it with people
Okay,
back
yeah.
at my paper.
Can you give me
Right.
everyone's email and I'll just
If
send
you
it?
send it to me, we'll shoot it to the group.
Good, okay, yeah,
Great.
That's perfect, and
All
then the
right,
links
I'll
will
do
be
that, yeah,
clickable. So yeah, thank you, good idea.
good,
This website is good, though, I was looking at it well.
thank you. Now, if any of you have got any ideas how I can make money on it, that would be welcome too.
Price gouging.
Price gouging, perfect. Okay, we are going